Hope all of you had a really good break. I hope you guys were pleased with the program calendar. I do apologize for the late send out on that, but we were able to adjust the calendar to allow for an official 13 start date. So I hope you guys were pleased with that. I felt better about it myself. And I hope you guys are excited about blood bank. So blood bank is my passion, what I have the most experience in, and I'm going to turn all of you guys into blood bankers, okay? When I was in this program, and internship coordinator at the blood bank here at UAMS told me that you have to have a healthy fear of blood bank. So it can be intimidating, and once you guys get in the blood bank, you might see that it can be a very stressful atmosphere because you'll have traumas come in. Here at UAMS, we are a level 1 trauma, so we get to see a lot of gunshot wounds, motor vehicle accidents, motorcycle accidents, stabbings, aortic aneurysms, anything that's very trauma, and we'll use a lot of blood products. And so the role of the blood banker is to make sure that we provide safe products for transfusion into those patients. We want to make sure that we give the right ABO. So if you give somebody the wrong ABO, it can be fatal. Okay, so that's one reason blood bank is sometimes so scary to students. So again, I encourage that healthy fear. Keep that fear, but become confident in your determination of ABO, RH, antibody identification as we dig deeper into blood bank topics. So just saying all that to say that I hope you guys will love it as much as I do, okay? In this lecture, this first lecture, we're going to talk about we're going to do some immunology review, and we're going to dive into ABO group system in lecture 2. Okay, so bear with me. Probably this first lecture will be a review on how our body builds antibodies. We're really going to concentrate, and I know you guys have all had immunology, and so after this course, a lot of students have told me if you guys struggled in immunology, maybe you did not like it. It is one of the courses that a lot of students say that was my least favorite course. And it's just because sometimes people have a hard time grasping the antigen antibody complex, what actually is going on. That is the main focus of blood bank. We want that antigen antibody complex so we can see agglutination. Okay, so we're really going to focus on making that antibody antigen complex. And so students tell me after blood bank, they have a better appreciation of immunology. Okay, so I'm hoping that will be the case this year as well. Okay, so what exactly is blood bank? And you might hear it referred to as some different terminology. You might hear it referred to as transfusion medicine. Some hospitals call their blood bank the Department of Transfusion Medicine. The big term for it is immunohematology because we are combining immunology with the cells. So a combination of immunology and hematology. So what we learned last semester, we're building on it this semester. So we're going to continue to talk about those topics. And so again, we're going to concentrate on the antigen and antibody complex. That's what we're studying in blood bank. That's what we want. Does the patient have the antigen? And if they lack the antigen, then guess what? They can build the corresponding antibody. And if they have the antibody, when we are thinking about giving transfusions, we want to make sure that the red cells we give them lack the antigen so the patient's antibody doesn't attack the product that we're giving. Okay, and a good word of advice for blood bank for you guys, I'll go ahead and say it now. You have to think about blood bank forward and backwards. Okay, so if you have a reaction, what does that mean? Where's my antigen? Where's my antibody? Am I testing patient plasma? That's where your antibody is, okay, in the patient plasma. Am I using patient red cells to determine what antigen is on the red cells? Your antigen is always on the red cells. Okay, so when we start mixing antigen and antibody, we're going to be using commercial antisera, right? That's your commercially manufactured antibody, will react with patient cells. If you're using reagent red cells, those are commercially manufactured red cells. The antigen is known. We're testing for the antibody in patient plasma. Okay, so always in the back of your mind, think, where's my antigen coming from? Where's my antibody coming from? Am I testing for patient antigen or patient antibody? Okay, and that will help you understand this course a lot. And our ultimate goal in blood bank, of course, is to find products for transfusion that is the safest for the patient. Okay? And typically in blood bank, when they order products, it's usually, if you guys are familiar with the donor process, they take off about 500 mils in the donor process. That unit can actually be broken down into 4 different components. Okay, so rather than a whole blood unit, they can do red cells, all right, so they can spin that product down, and we'll talk in depth about this process later on. They can get red cells. They can actually do your Buffy coat, all right, so the white cells, if they wanted to give granulocytes only. They can do platelets, and they can do plasma, all right, and they can even, if you really want to think about it, they can break that plasma down into a step further and get cryoprecipitate. So really there's 5 products from 1 whole blood unit. Back in the old days, we're going to talk a little bit about history in just a minute, but whole blood donations used to be a thing where you went, you donated blood, 500 mils, it had red cells, plasma, white cells, and platelets, and they would just give all of that to the patient when they needed a transfusion. That's a whole blood transfusion. However, there's a huge concern with that. You have volume overload. So maybe the patient only needs oxygen carrying capabilities, then they only need red cells. They don't need the plasma, they don't need the platelets, they just need the red cells. And so that's why we kind of break that whole blood unit into all the different components. And so what we're going to study is why we give those components and how we find the safest components for the recipient. Okay. All right, so just a little bit of history on blood bank and transfusion. It's actually documented that the first transfusion occurred in 1492. Any of you guys familiar with Pope Innocent VIII? It was thought that he was very severely sick, and it's recorded that 3 shepherd boys made a donation to him. Depending on what reference you look at, they say that he drank the blood of these 3 boys, and then ultimately he died from that. And so they tried to tie it back to the blood from the 3 boys being ultimately what caused his death. Who knows, it might have been his illness that caused his death, but that's the first recorded transfusion in 1492. In 1613, there was a huge discovery by William Harvey. He discovered that the blood circulates in the veins. So what this discovery allowed is they were able to enter the veins at this point, and they used needles and insert things into the circulation. Okay, and then in 1667, we had the first animal to human transfusion. And it was a French physician, Jean-Baptiste Denis. There was a young boy that was sick, and he transfused that young boy with blood from a lamb. That boy actually survived. And if you look at this, research the history of transfusion, you'll look up, there'll be other animal to human transfusions. Some survived, some didn't. It was ultimately determined that animals have different proteins in their circulation, not compatible with humans. And so that is why animal to human transfusion, of course, is not common practice. And then in 1824, James Blundell introduced vein-to-vein transfusion using a syringe. However, if you guys know, we're going to talk about this, we use anticoagulants for our blood. And so doing a direct transfusion from donor to recipient, the blood was clotting, and that caused a huge issue. So that was the concern there. And then in 1901, we have Dr. Carl Landsteiner. How many of you guys have heard of him? He is the founder of the ABO blood system and agglutination. So him and his group of researchers in their lab, they drew each other's blood and they started mixing each other's red cells and plasma, and they noticed agglutination. And so they were able to identify 3 different ABO systems, the A, the B, and at the time they called it the C group. We all know now the other group is the O, and then also you have AB. So he was the original founder of the different ABO groups. And then it's in 1921 that the volunteer blood bank services was introduced in Europe. They actually pioneered it. It was not actually until the 1930s that the volunteer blood donor services, which we know as the American Red Cross, started in the United States. And it became huge. They started using blood bank products in World War II for all the troops in battle. In 1941, we had the discovery of the Rh, so the rhesus. So if you had the D antigen on your red cells, you're Rh positive. If you lack the D antigen, then you're Rh negative. And so we'll get into the Rh antigen as well. I talked a little bit about components. Like I mentioned, they used to do whole blood transfusions. Now we break the whole blood into various components depending on what the patient needs. And as we go through this semester, we're going to talk about testing on these donor units. We do a lot of infectious disease testing on these units before they're deemed safe for transfusion. And it all goes back to AIDS because we'll talk about Ryan White, who was a little 8-year-old boy who had hemophilia A. So he had recurrent plasma transfusions from donors to replace his factor VIII. And he ended up becoming HIV positive. He had AIDS from all of those transfusions. So it was actually him and his mom that led efforts in all of the infectious disease testing on our products. We'll talk about him more when we start talking about infectious disease testing of our products. All right, and like I mentioned, the main point of blood transfusion, we want to have a successful transfusion, okay? We want whatever we're transfusing into the recipient, whether it be red cells, plasma, we want the recipient to accept it, okay? So it has to be compatible. We'll talk a lot about compatibility, antigen negative, safe for transfusion. We're going to complement that. And we want to only replace what the patient is lacking, okay? So if they have been in a trauma, they've lost a lot of blood, they might need oxygen carrying capabilities and volume replacement. So maybe red cells and plasma are good for them, maybe even platelets, depending on how much blood they have lost. Maybe your patient just has severe anemia, okay, and they need oxygen carrying capabilities. We just want to give them red cells. A lot of our chemotherapy patients, maybe they have pancytopenia, so they're probably going to get red cells and platelets transfused. In severe cases, you might even give them granulocytes. Granulocytes, rare occasions. And again, when we start talking about expiration dates of our products, granulocytes only are good for 24 hours from collection. So that requires a lot of communication between the requesting physician, the donor center, and then the receiving hospital where it's going to be transfused. Okay. So keep in mind what your patient lacks. We need it to be safe. If it's incompatible with that recipient, their immune system is going to destroy it. It does them no good. They're still going to have the symptoms that they initially presented with. Okay. So that's our ultimate goal in blood bank, to replace the product your patient is lacking and make it safe for them. We don't want them to have any adverse reactions from that transfusion either. Okay. So whether that be infectious disease, maybe that unit, they do a lot of nucleic acid testing now for like West Nile virus, HIV. So maybe the unit was initially tested negative, but then that donor comes back 8 weeks later and now they test positive. Okay, so if you potentially expose that recipient to a infectious disease, that's some type of adverse reaction. Or maybe you give your recipient the wrong ABO and they have a hemolytic transfusion reaction. That's an adverse reaction. Okay, we don't want that to occur. Okay, so that's the role of the blood banker, is to prevent those adverse reactions. And we'll talk a lot about that in this course. Okay, so just a little bit of immunology review, and I hope this is a review for all of you guys. Remember, immunology is the process where the body is protected from disease and foreign invaders. So think about whether that be bacteria, or virus, or in the case of blood bank, maybe the patient has been transfused, they're exposed to an antigen on the donor red cells that they are negative for. Then when the body recognizes, hey, that antigen, I've never seen it before, it's foreign, I'm going to build an antibody to it. Okay, that's your body's response. And so that's oftentimes, we're going to talk about different ways that patients build antibodies. Are they naturally occurring? Have they been exposed? The way that you can be exposed for females, if you have a previous pregnancy, if your baby is antigen positive, you are antigen negative, you can build an antibody to whatever your baby's antigen is during the fetal maternal blood exchange. Okay. If you've had a previous transfusion, you can, if you're exposed to donor cells that have the antigen that you like, you can build the antibody to it. Okay. So we're going to talk about the body recognizes those antigens as foreign. They must recognize from self versus foreign. All right. The body's going to say, hey, I've never seen this antigen before. I'm going to respond to it. I'm going to launch an immune response. Okay. And we're going to talk about two different types of immune responses. So what happens if your patient builds that antibody? All right, it could cause intravascular hemolysis depending on what type of antibody it is. And you guys have all talked about the different types of antibodies, IgG, IgM, IgA, IgE. Two main antibodies that we're going to talk about in blood bank, IgG and IgM. Okay, that's the two that we will primarily focus on. So depending on what type of antibody your patient has, will determine the effect. Okay, if it's an IgM antibody, those are typically more severe. They're larger in size. They can result in intravascular hemolysis, okay, immediate cell destruction, such as a incompatible ABO transfusion, or is your antibody IgG. So usually those are not as severe, will attach to the red cells. Your spleen will recognize that as foreign, resulting in extravascular hemolysis. So the symptoms of that are not as severe as intravascular hemolysis. And we have some tests that we'll talk about in blood bank to differentiate which type of antibody is coating the patient's cells. Why is hemolysis occurring? Is it due to complement, or is it due to some type of antibody, whether it's IgG or IgM? So speaking of complement, if you were to give your patient a wrong ABO transfusion, our ABO antibodies are IgM, very large. They can activate complement. That will result in intravascular hemolysis. It's going to cause immediate problems. Oftentimes that transfusion will only have lasted probably about 10 minutes. The nurse probably just started it. The patient's going to start immediately complaining of side pain at their kidneys. Fever is going to spike. If that transfusion is not immediately stopped, you have intravascular hemolysis occurring. You have red cell fragmentation. Those fragments are going to travel to the kidney, can cause kidney damage. Those cells can initiate DIC. Okay, so that is why the wrong ABO is so fatal. It's going to cause your patient to go into DIC. Okay, and they're going to have intravascular hemolysis, so they're going to be losing cells immediately. Okay. And again, so it's that intravascular hemolysis that is more severe than extravascular hemolysis. Okay. And you guys all remember from immunology, you remember the, I almost said coagulation, the complement cascade. Okay, so once complement is activated, C1, C3, C4, C5, 6, 7, and then that 8 and 9 complex attaches to the red cell. Once that 8 and 9 complex is on the red cell membrane, it's going to puncture a hole in the cell. Ultimately, that will cause cell lysis. Okay, that's what happens in the wrong ABO. In extravascular hemolysis, typically, you'll see this with IgG antibodies. It just attaches to the red cell. Your spleen and your liver can recognize that as foreign, and then they'll just destroy the cell that way, extravascular.
What if your patient has had a splenectomy?
So if they've had a splenectomy, then those cells just remain in circulation longer periods of time. The liver might help as well, try to clear those cells, but typically they'll just be in circulation for the length of their life. We'll concentrate a lot. We have a whole section on moms and babies. And so I mentioned if the baby is antigen positive for the antigen that mom lacks, she can build an antibody. If that antibody coats baby cells, then those cells will be destroyed. And that can cause severe anemia in the baby. It can cause respiratory distress in the baby if it's not treated. Any of you guys ever heard of an intrauterine transfusion? Sometimes if it's a very severe case, they will do a transfusion into the baby while he's in utero. So that's a technique that we'll talk about in our mom and baby section. Okay, so there's two types of immune responses, and I want to use the board to really display this. So we're going to talk about, and this should all be a review, cell-mediated versus humoral immunity. You guys remember that? All right, I want to just review that really quick, and then how that applies to blood bank. Pause that. Well, it's been used in a while. Okay, so let's say we're inside the body, right? We're going to use bacteria because it's easy. Okay, so you have bacteria. Here's your bacteria. It has all of these specific antigen sites on it. Okay, these are all your antigen sites on it. The body's going to launch two types of immune responses. You have cellular, cell-mediated, involving the T cells. Okay. You have a phagocytic cell here. Here's your bacteria. Your phagocytic cell can engulf it, right? And then this phagocytic cell becomes an antigen-presenting cell. So your bacteria is engulfed. All these antigen sites that were on the bacteria are now on this cell. Excuse my drawing, all right? So here's your antigen-presenting cell. Now has all of the antigens being exposed on it. So it will present those antigens to what? To your T cells, okay? So here's your T cells. You have two different types of T cells, right? You have your CD4 helper cells. You have your CD8 suppressor. Your CD4, once they're activated, they can activate your natural killer cells. They're also going to release cytokines. And then what's ultimately going to happen is your T cells now express those antigens that were on the bacteria. Those antigens, or receptor sites, I should say, can bind directly to the bacteria. And guess what? They can directly kill the bacteria. Okay. Same thing would apply if this was a virus or donor cells where a new antigen has been introduced into the patient's body. Okay. All right. Versus, so that's cellular. Now we have humoral. Okay.
Is suppressor the same thing as cytotoxic?
Yeah. So then your suppressor cells are going to become cytotoxic. Cyto meaning cell, toxic meaning it can ultimately aid in cell death as well. Humoral. So you have your bacteria. Think about your bacteria. Remember I mentioned those specific antigen sites all along? Those specific antigens on that bacteria have specific epitopes. That should be a triangle. Kind of looks like, let me do this. There you go, right? Specific epitopes, those antigens. Okay, so on your B cells are, and one thing that you notice that your CD4 helper cells, they have the antigens on them now, right? They can actually present to your B cells as well. They can activate your B cells. What do B cells become when they're activated? Plasma cells. What do we know about our plasma cells? They produce our antibodies. So on your B cells, there's here's your antigen from the bacteria. There's receptor sites on your B cells that can bind to that bacteria, right? Because they've been stimulated by the T cells, right? So now they can bind to that bacteria, activating the B cells. B cells are going to transform into plasma cells, and then the plasma cells are going to build clones of cells that recognize this bacteria, and then they will build antibodies to that bacteria, okay? This is not effective at immediately fighting this infection. This is to recognize future exposures, all right? And so you'll have your memory B cells producing the antibodies.
Something I think if it encounters proteins.
Proteins. So these are proteins.
I remember that from immunology, the memories that I haven't repressed, that it has to have like the B cell has to encounter like a certain antigen in order for it to become memory cell.
Yeah, yeah. So once it's exposed, let's say to this bacteria, then it now recognizes it. It's going to build antibodies. These antibodies will help fight off any type of future exposures. Does that make sense? All right. So then you have these antibodies that can attack the bacteria, attack your donor cells. What's going to happen? How? Well, okay, yeah, it could. It depends on what type of antibody it is. So what's going to happen is these antibodies will attack, whether it's bacteria, cells, they're going to you'll have the antibodies attached like that. And then this can allow in circulation until it gets into the spleen. And then the spleen will destroy this, resulting in extravascular hemolysis. Okay? This is what we will typically see when these antibodies are built, and then on re-exposure, it will attach to whatever the object is foreign, red cells, bacteria, virus, and then the spleen can take it out. Does that make sense to everybody?
So cellular is intravascular and humoral is extravascular?
I don't want to make that distinction because it depends on what type of antibody is being produced. If this, you could also have B cells producing, because your B cells produce a specific clone of antibodies. So if you have a amnestic response, a secondary immune response, like if you've already been exposed to it, typically it's going to be IgG related, which would be extravascular hemolysis. If you have an IgM antibody, such as the wrong ABO or some of our cold reacting antibodies, that could result in intravascular and extravascular as well. So it depends. I don't want to make that specific connection. It just depends on what type of antibody is being involved. I'm clearing this off, and I will post this chart. If it's not already there, I'll post it in the Lecture1 section in Blackboard. It's a lot more detailed. But from that, what I want you guys to remember, humoral immunity involves your T cells, your CD4, your CD8, your cytotoxic, and your natural killer cells. Okay. Humoral involves your B cells transforming to plasma cells producing antibodies to destroy whatever foreign object has been introduced into the body. Okay. Complement, if you are dealing with the IgM antibody, most oftentimes all of your IgM antibodies can activate complement. Once complement is activated, like we mentioned, it will attach to that cell membrane, ultimately resulting in cell destruction. And that's intravascular. We have a whole lecture dedicated to the complement cascade, what happens, how we detect that in blood bank. One thing is, if you guys think about the complement cascade, you think about C3 and C3b and C3d. When complement has been activated and the cascade has completely gone through its process, C3b and C3d remain on the cell membrane. So we are able to detect that in our blood bank testing. When we are testing, when we do our DAT and we are looking at what is coding patient red cells, that is how we detect complement. Okay, and that's how we can tell that complement has been activated. And again, we have a whole lecture coming up on that. And this is just to demonstrate what's going on when complement has been activated. Notice that when C1 is activated, you have C4 that's activated, which C2A will cleave, C3b. So you have C3b is more involved in the phagocytosis process. C3A is going to be involved in inflammation. It's going to cause your vessels to constrict. And then as the coagulation, not coagulation, still second hematology, complement cascade continues, you'll have your C5, C7, C8, C9 complex attached to the cell, ultimately resulting in cell lysis. Okay. And again, we'll talk in depth about complement in a future lecture. Okay, so what exactly are antigens? Think about antigens as being substances capable of inducing an immune response in your patient's body. Okay, whether that antigen is on a bacteria, whether that antigen is on a virus, whether that antigen is from donor unit cells, okay, whether they're red cell antigen on the cells. They're usually composed of protein, carbohydrate, or a lipid. And again, they may be free, such as on the bacteria membrane, or they're attached to your cells, whether that be your patient cells or your donor cells. If you think about, take it back to hematology and think about your red cell membrane. Remember we talked about how the structure of that red cell has proteins in it, and then you have some glycoproteins that are within that, and then some carbohydrates that extend from those proteins, all right? So this is your carbohydrate molecule here, indicated right here. This is where your ABO antigens would be. They are consisting of a oligosaccharide, so several sugars mixed together. And we're going to talk about that in the next lecture. And then on some of them, you'll have your RH antigens, your Duffys. It is thought that if your antigen sites protrude from the cell, that they are very antigenic. Okay, so that makes sense. Our ABO antigens are very strong, very antigenic, as well as our RHs. Okay, they're very strong too. And that is just because they kind of extend from the cell rather than being directly on the cell membrane as some of our other antigens that we're going to talk about. And then our antigens. We'll talk about the epitope. The epitope is the portion of the antigen where the antibody combines. And we'll talk about the process of goodness of fit when we are trying to detect if a patient has an antibody or if we're trying to identify the antigen on the patient's cells. We want a goodness of fit. We want the antibody to fit the specific epitope of the antigen. Okay? And think about it as a lock and key. Like we want the antibody to attach to that antigen. Once that occurs, that gives us agglutination. We are able to visualize that in blood bank. That's what we are looking for. That lets us know your patient has the corresponding antibody or antigen, depending on how we're doing our test. Okay? So that's your goodness of fit. If for any reason the epitope changes or anything like that, that affects the binding of that antibody to the antigen. And that will affect how well we can detect it. And part of blood bank is encouraging this antigen-antibody complex to occur. We want this to occur. So we have some enhancement media. We have some ways that we will try to induce this agglutination. And everything in blood bank is for a reason. So when we centrifuge our specimens, we're encouraging the antigen-antibody complex. We're pushing them closer together. When we incubate at 37 degrees, some antibodies have a desired temperature of reaction. So we want to mimic what's going on inside the body to allow that antibody to react. okay? And so everything is for a reason. And then if you're dealing with an IgG molecule, which we'll talk about in just a minute, think about how small it is. You guys remember from immunology, it has just 2 antigen binding sites versus IgM has 10. Okay, IgM is very large. Usually it does not need any encouragement to allow for agglutination. Okay, we can pretty much visualize that. It's going to be a pretty strong reaction. IgG is so small, it has a harder time breaking down that zeta potential and bringing the cells together so we can see agglutination. Okay. How can you build antigens? Usually you can, through anything you're exposed to, let's say ingestion, inhalation, it's in the air you breathe. Like for your ABO, you have the antigens on your red cells, right? How do we build the corresponding antibodies to the ABO? So your ABO antibodies are naturally occurring, they're IgM. And so remember, if you lack the antigen, you can build the antibody. So if you're type A, you have the A antigen on your red cells, but meaning that you lack the B antigen, so you will have anti-B in your plasma. Where did that anti-B come from? Naturally occurring, it's in the air you breathe. Usually about 6 months of age, you'll start building those antibodies. Okay, so it's in the food you eat, being exposed to things, the air you breathe. Those are naturally occurring. And we talked about our antibodies. They are proteins, immunoglobulins produced by the plasma cells. Usually they're produced by the direct exposure to an antigen, or if that macrophage becomes exposed to it and becomes an antigen presenting cell. And then again, here's your plasma cells and then your antigen presenting cells. All right, 2 types of antibodies you guys need to be aware of. We have allo antibody, and that is an antibody to a foreign substance, okay? That's an allo antibody, something that you are lacking, you are antigen negative and you have built an antibody to it. Okay, that's an allo antibody versus an auto antibody. Auto antibody is when you build an antibody to yourself, okay? Auto antibodies are blood bank. How do I word it? We hate auto antibodies, right? Because the patient's going to react with himself. Everything is going to be positive, and it's really hard to rule out any underlying allo antibodies. Okay, and you guys, as we start talking about auto antibodies, you'll see what I mean by that. All right, still in immunology review, the immunoglobulin structure. You guys all remember your immunoglobulin has 2 heavy chains and 2 light chains. The heavy chains are constant, okay? And for IgG, that heavy chain is gamma. For IgM, that heavy chain is mu. That's why we call them IgG versus IgM. And then you have 2 light chains. Those can be variable. It can be either lambda or kappa, okay? So whatever your heavy chain is determines what type of antibody you have. Is it IgG or is it IgM? In blood bank, those are the 2 that we are most concerned with. Okay. And here's your immunoglobulin structure. I'm hoping you guys have all seen this before. You know what it looks like, but just as a review, your heavy chains are on the outside. Okay, here's your heavy chains, and then here's your light chains. And then you have your FAB region right here. And this is where your antigen binding site is. Okay, so your antigen binding sites for an IgG molecule, you have 2, one here and one here. And then here's your FC region, your crystallizable region. This is your complement binding region. Also, there are some receptor sites on here, neutrophils, and other things can bind to these immunoglobulins as well. If you notice, it's kind of like a mirror image. If you were to divide this down, you have a mirror image. Notice that you have a hinge right here in the middle. This is composed of disulfide bonds. We have some processes in blood bank that we will talk about where we will break this disulfide bond up and we will open up the IgG molecule to allow for further binding. And so just remember that hinge region allows for flexibility in that molecule as well. It kind of lets it move around better meet the antigen to allow for binding. We also have some enzyme processes that we can do that I mentioned. It'll break those bindings and allow the IgG molecule to kind of open up and hold on itself. And so this just differentiates the two differences between IgG and IgM. Remember, IgGs are very small. Okay? They're very small in size. They have 2 binding sites. Your IgM molecule is very large. It is joined by the J protein in the middle, and it actually has 10 binding sites. Okay, so when we think about agglutination, and you guys start doing your ADO interpretations that we're going to do tomorrow in lab, those are all IgM, and so they can react with the agglutination after initial scan. One concern with IgG is they're so small, they have a hard time breaking down that beta potential, allowing all the cells to come together. We usually have to incubate them, maybe even add an additional reagent to be able to see agglutination with these guys. Okay? And we're going to talk about the process of agglutination. There's actually 2 stages. We have what we call sensitization, where the antibody attaches to the red cells, but maybe, and how we see agglutination in blood bank. Let's say you're dealing with an IgG antibody, it's going to attach to the red cell, but it's so small in size, maybe it can attach to another red cell. So if any of you guys think about agglutination, when we see agglutination, that means the antibody is bringing multiple red cells together, kind of like a cluster of grapes. And that is what we look for in blood bank. That's agglutination. IgG has a very hard time of bringing those red cells together because of its size. Okay, so we have some tests in blood bank to help IgG. So when we do our ADL determinations tomorrow, you're dealing with IgM antibodies. There is a disclaimer with that I'll get to in lecture 2. Okay. This is all review for you guys, right? IgG versus IgM. Okay. So let's just talk about some of our IgG and IgM characteristics. I mentioned that IgG is your gamma. It only has 1 monomer, so 2 antigen binding sites. Think about the size of IgG compared to the size of IgM. Remember I mentioned IgG is small. It has the capability to cross the placenta. Okay, keep that in mind. That is very important in blood bank when we start studying moms and babies. Okay, because if mom has an IgG antibody, guess what? It can cross the placenta. It can attach to baby red cells. It can cause respiratory distress in the baby, can cause anemia, that will ultimately end up in early delivery or intrauterine transfusion, depending on how severe of a case it is. We have a whole section that talks about hemolytic disease of the newborn, right? And that is why, because mom's IgG antibody can cross the placenta. Okay? Versus IgM, they're so large in size, it's not going to get across that placenta. Okay, so some of our IgM antibodies that we'll talk about, such as lupus A, lupus B, those cannot cross the placenta. So we'll start talking about clinically significant. Other than our ABO antibodies, a lot of IgM antibodies are not considered clinically significant. Okay. And remember, our IgM antibodies can definitely activate complement. There's only a couple IgG antibodies that have the capability to activate complement. And when we start talking about our IgG antibodies, we'll identify those. And remember, naturally occurring. IgM antibodies are typically naturally occurring. IgG antibodies are typically only built after exposure. Okay, so for females, if you've had a pregnancy, you can build an IgG antibody. Not a problem for your current pregnancy. It's a problem for any future pregnancies. Okay, so if mom is Rh negative, the dad is Rh positive, baby gets that D antigen. So mom is Rh negative, baby's Rh positive. If mom's exposed to that D antigen, she could build anti-D. Anti-D is the most antigenic antigen that we have. Any of you guys ever heard of RhoGAM? All right, so RhoGAM is given to pregnant females who are Rh negative to prevent, kind of like a prophylactic treatment, to prevent the production of anti-D. It's the only antibody that we have that capability for. Any of you guys ever invent something for kale? Kale is the next most antigenic. Why we don't have something for kale, I don't know yet. But if you guys ever invent that, you could be rich. So, all right, so if you guys ever heard RhoGAM, you know somebody that received RhoGAM, that's the reason why they were Rh negative. If they don't receive RhoGAM, they could potentially build anti-D, which could coat future pregnancy, future baby cells, and that could result in hemolytic disease of the newborn, early delivery, intrauterine transfusions, or ultimately fetal death if it goes untreated. That's how severe it is. Okay. And like I mentioned, we have some enhanced anemia that we will use with IgM. We don't have to use that because that molecule is so large. We will be able to visually see that agglutination. Versus IgG, we kind of have to encourage it. We have to help it. Okay, this is very important. Location of your antigen and antibody. I've already said this, but I want to say it again. If you can wrap your head around this, blood bank will be very easy for you. Okay, your antigen will always be on the red cells, whether you're testing patient red cells, whether that be a donor or a recipient, or your phenotyping donor cells. Okay, we're identifying antigens on the donor cells, or you're using reagent red cells. Your reagent red cells provide the known antigen. Okay, your antibody is in the plasma. Okay, so if you're using patient plasma mixing with reagent red cells, we're identifying the antibody in the patient. And remember the rule, Landsteiner's rule. If you lack the antigen on your red cells, you can build the antibody in your plasma. Okay, so where are your red cells? Where are your antigens? On the red cells. Where is your antibody? On the plasma. Okay, so remember I said you have to think about blood bank forward and backwards. So if you're doing patient testing and you're doing your forward testing, meaning that you're looking for the antigen that's on your patient red cells. If you're doing your reverse testing, you're using patient plasma, you're testing for the antibody. Okay, so whenever you're trying to identify, blood bank can get complicated. Straightforward, it's easy, but there's always discrepancies, there's always problems. And that's where blood bankers become really good problem solvers, is that you have to ask yourself these questions. Okay, where's my discrepancy? Is it an antigen problem or an antibody problem? Okay.
So people with autoantibodies, it would be the antibody problem?
So people with autoantibodies, they have an antigen on their red cells that they have built an antibody to. Sometimes we will see that after an infection with like infectious mononucleosis or mycoplasma pneumonia. That virus causes the patient to build that antibody. And if they have anti-I on their red cells, anti-big I is a known autoantibody. We'll see it quite frequently in blood bank. They have the anti-I on their red cells. Then they have the antibody in their plasma. It's a self-antibody. It's an autoantibody. Will cause reactions. Okay, so that kind of gets deeper. We're not there yet, but we do an auto control where you'll mix patient cells with patient plasma. Your auto control is going to be positive, of course, because the antibody is attacking the patient's own cells. And so anytime you have a positive auto control, that indicates a autoantibody. And drugs can cause a positive auto control as well. We'll get all into that. So we talked a lot about the antigen-antibody complex. We want that in blood bank. I think I've made that clear. Sometimes we have to create that reaction in the laboratory. Okay, we're looking for that antigen-antibody complex to occur. We want that agglutination. And that antibody-antigen complex is dependent upon the structure of the molecule. If you think about IgG versus IgM, the epitope of your antigen, it's referred to as the specificity. I have a hard time saying that word. And so sometimes, like when we add our reagent antisera, let's say you're doing the D testing. So we're testing for the D antigen on our patient red cells. Our antisera is anti-D, all right? So that D antigen has a specific epitope, and then your reagent is the specificity of your anti-D is to that epitope of the D antigen. Does that make sense? And then here's your good fit that I mentioned earlier. And depending upon your good fit, what type of binding, is it hydrogen, is it ionic, is it electrostatic? And then in blood bank, we can encourage this good fit by incubation temperatures, time, the pH of our saline that we use. any enhancement media that we add. It is all to ensure the good fit. Think about it as the lock and key. Antigen and antibody complex occurring, okay? So the antigen-antibody reaction occurs in 2 stages. The first stage is going to be sensitization. That means that the antibody has attached to the antigen on the cell, okay? In certain cases, we might not be able to see that. If it's an IgG reaction, IgGs are so small, it might have, the antibody might have bound to the cell, but we are unable to visualize that because it's so small, okay? Versus the second stage, that is true agglutination. That's where the antibody has bound to multiple cells, and then we have the cluster of grapes, we have agglutination. Okay. So sensitization means that the antibody has attached to the antigen, but we are unable to visualize that. If you think about this, you have a number of red cells, you have some plasma added. For an antigen-antibody complex to occur, that's really just by chance, right? Especially when we're taking patient plasma, mixing with screening cells. This is your antibody screen. We have the antibody screening cells have a known antigenic profile. So we know what antigens are on those cells. What antibody is present in patient plasma, that's the unknown. That's what we're testing for. So to have a reaction, to have sensitization and agglutination, really just by chance, okay? So we're adding it, we're seeing what happens. We don't know in the screening phase, okay? So we try to increase probability of that collision. So if you think about red cells being on the surface of your, or antigen being on the surface of your red cells, antibody being in your plasma. We mix them together. You have a lot of forces that are in place to prevent that agglutination. You have the zeta potential, the negative charge around the cells that naturally repulse them from each other, keeps them from coming together, right? We have that working against us. And so that's one reason some of the things we do in blood banks, such as centrifugation, bring those cells together, break down that zeta potential so we can view that agglutination, okay? And so another thing that we will do is we'll increase the antibody. So oftentimes when we start talking about our ABO determination and we add plasma to our test tubes, we add 2 drops of patient plasma, 1 drop of cells. And that's only to increase the amount of antibody, to increase the concentration of the antibody. That should allow more chance that the antigen-antibody complex will occur, okay? And that's really just to refer to as the serum to cell ratio. So increasing serum or plasma will increase the chance of that collision, all right? Increase the likelihood of that sensitization occurring. Increasing the red cells will not, okay? So if any times you're testing, you don't see any agglutination, but you suspect it's there, we might try to increase the amount of plasma. And then again, some environmental factors that we try to control: temperature, number 1, incubation time, centrifugation. And remember, IgG antibodies typically react at 37 degrees, okay? They're warm reacting. IgM are what we call cold reacting or room temperature reacting, okay? And so sometimes after initial spin, that means incubation at room temp, we immediately spin and read for agglutination. Our IgM antibodies will react. Our IgG antibodies will not. We have to carry it through an incubation phase, and usually we'll add a reagent to it to enhance it, okay? pH is important too. We have our blood bank saline, normal saline, and it's usually about pH of 7, and then our ionic strength. And we're going to talk about this. I believe it's in lecture 3 or 4. We'll go into depth about all of these. The incubation times, your temperatures, centrifugation speed, and everything like that. We'll go into depth of that. Okay, so after sensitization, after that antibody has attached to the red cells, we want to develop what we call lattice. So what's going to happen is the antibody is not only going to bind to 1 red cell, it's actually going to bind to multiple red cells. That's what gives us are agglutination. Okay, that's what we can see in blood bank. That's what our desired reaction is. Okay. I wish I had a better whiteboard, better access. So here's what's going on to really how we visualize agglutination. So here's your test tube, okay? Let's say you have patient plasma and you have reagent red cells. We were doing a back type maybe. So here's your red cells with the antigen. These are commercial red cells, okay? The antigen is known. We add our patient plasma with the antibodies. What's going to happen is the antibody desensitization will bind. We can't see that yet, all right? We're unable to see that. This is sensitization. In agglutination, after we centrifuge, after we incubate at 37 degrees, then what's going to happen is the antibody that's already bound is going to bring, whoops, can't bind there. I have a hard time drawing. Going to bring red cells together. We can visualize that. That is agglutination, when you have a cluster of red cells together. That's what we look for with agglutination. Does that make sense to everybody? Now, how we get there, sometimes we have to encourage. Whether we add some enhancement media, we increase our incubation. There's a reagent that we'll use is called AHG that you guys will learn about. We add it to further enhance the lattice formation of the IgG antibodies. And so I mentioned this, agglutination is influenced by the distance between the red cells. So we have that zeta potential working against us, okay? Often, especially with IgG. IgG is going to have a hard time because that zeta potential, the negative charge surrounding those cells, is going to naturally repulse those cells. So they're going to want to be away from each other. We want them to come together, okay? So there's some enhancement media that we'll add to break down that zeta potential. That's one reason we centrifuge, to try to force them closer together so we can visualize that agglutination. And then we want to make sure that we have the zone of equivalence, okay? We want to make sure that we have equal amounts of antigen and antibody to allow for agglutination to occur, okay? That's called the zone of equivalence. And we use normal saline, so we'll use a 0.85% normal saline, and it kind of, so if you have a negative charge around the cells, that normal saline, the cells are happy in that normal saline, and it's kind of supposed to help aid in breaking down that zeta potential. And you guys remember, did we talk about zeta potential a little bit? You guys remember that it's the cells are surrounded by the negative charge. That charge makes the cells repel each other. Okay, so that's what we're fighting in blood bank. We'll talk about that a lot. And like I mentioned, IgM, typically don't have a problem getting agglutination with IgM. It's IgG that we have to encourage the visualization of agglutination. because they are just so small, they have a hard time breaking down that zeta potential. And so here's an example. Here you have your negative charge surrounding the cells. Notice that IgM with its multiple binding sites, it is better able to bring those cells together. So not only is it larger in size, can break down that zeta potential easier, but it has more binding sites. And so more cells are able to come together, so we're able to easier visualize agglutination with the IgM molecules. And so notice this is what agglutination looks like. And this is an IgM antibody. So that's what agglutination is. And I mentioned that zone of equivalence, all right? So we want equal amounts of antibody, equal amounts of antigen. And we want to avoid, did you guys talk about prozone and postzone in immunology? We want to avoid excess antibody and we want to avoid excess antigen. Both of these, are you guys listening to me? Both of these will cause false negative reactions, okay? If you have too much antibody, too much antigen, if there's too much antigen and all the antigen sites are bound up, or if too much antibody and all the antigen sites are bound up, that could cause a false negative. If there's not enough antibody present, that could also cause a false negative. Okay. A good way I like to remember this, if you think about prozone, think about pro athletes having good body. I mean, I don't know. That's how I remembered it. So if you guys have any problems with that, just remember prozone, excess antibody. Postzone, excess antigen. And so this is what it should look like. In the happy medium, where you have equal amounts of antibody and antigen, allows for equal agglutination to occur. Notice if you have prozone, right, too much antibody, all the antigen sites are bound up, we will not be able to see that visualization of agglutination. Okay, that's a false negative. If you have too much antigen, okay, that's also a false negative. We won't be able to visualize the agglutination. So this is where we want to be. We want to be able to see that agglutination occur, the antigen-antibody complex occurring. Time and speed of centrifugation, very important as well. Again, centrifugation forces those cells close together, allowing for that agglutination. So we're going to talk a lot about reactions in blood bank. We'll grade our reactions. There's some subjectivity there. But whenever you think about a positive reaction versus a negative reaction, there's another reaction that you always have to keep in mind. And that's if after you're doing your testing, you're reading your reactions and you notice any type of hemolysis. So if your patient plasma was yellow prior to adding to the tube, and after you spin down, now your plasma has a red tinge to it and your cell button is really small, that means hemolysis occurred, cell destruction. Antigen antibody complex occurred and it resulted in immediate cell lysis. Okay, so hemolysis is always considered a positive reaction in blood bank. Why? Because complement can immediately hemolyze the cells. Okay, so if you ever have hemolysis in your test tube reaction, it's probably an antibody that can activate complement. And so just to further differentiate primary immune response from secondary immune response, this should also still be a review from immunology for you guys. Remember, upon initial exposure, you'll have your B cells, you'll have your plasma cells being activated, producing the antibody. Typically, in initial immune response, those are IgM related. So with primary immune response, the antibody being produced is typically IgM. Okay. After exposure, those titers of that antibody is going to drop down. Right? If that patient were to ever be exposed again to the same antigen, and then upon secondary exposure, secondary immune response or amnestic response, then it's typically going to be of IgG antibodies. Okay? So IgM associated with primary, IgG associated with secondary or amnestic response. So you have this kind of lag phase in the middle here. That's where your titer drops down low. When we do our blood bank testing, and we'll talk about some of the antibodies that are known to do this, like your kid family is notorious for this. Their titers drop down really low. In our blood bank testing, We are unable to detect antibodies when the titer is so low. So what's going to happen? If your patient has a previously JKA antibody that was identified, the titer is so low right now that it's undetectable, that patient gets transfused with a JKA positive unit. It's going to cause a secondary amnestic immune response of IgG antibodies. That patient's going to present with a delayed hemolytic transfusion reaction. Everything's going to seem okay until about 2 to 3 days later. Okay, 2 to 3 days later, that patient's going to present symptoms of anemia, jaundice, being real tired. Okay, maybe even longer than 2 to 3 days, maybe 7 days later. It just depends on how quickly that titer of antibody increases. Okay, so that's the difference between primary and secondary. And we'll talk about which antibodies are notorious for this. JKA is the number one. Okay, so that completes lecture 1. Anybody have any questions on blood bank so far?